Hi, I'm Miriam, and today we're covering acute and concerning skin conditions. The skin is the body's first line of defense, so skin reactions can signal things like infection or immune reactions or cancer. So as we move through these conditions, I want you to focus on one question. What is the priority action that the nurse should take? Now let's start with one of the most serious medication reactions you can see, and that's Stevens-Johnson syndrome, or SJS. SJS is a life-threatening skin reaction to medications where the skin blisters, peels, and begins to detach. Ouch! So you might be wondering, what medications cause this? Well, a helpful memory trick is the 3 A's. So antibiotics, especially sulfa drugs, anticonvulsants like lamotrigine, and allopurinol. Now, we definitely want to catch this early. So you're giving a client a sulfa antibiotic and the client starts to have a reaction. What might you see on assessment? Well, it'll often start with flu-like symptoms such as fever and malaise, and then the rash will develop, painful blistering, skin that peels and detaches. And this can involve those mucous membranes like the mouth, nose, or in the respiratory tract. And that's going to increase the risk for respiratory complications. And if you see 30% or more of the skins involved, it's going to be classified as toxic epidermal necrolysis, just a name change that signifies that it's more severe. So if you suspect SJS, what should you do? Well, the priority intervention is going to be to immediately discontinue that trigger medication. That's your NCLEX priority. If you see blistering and peeling skin after one of those 3 A's, remember to stop the medication. Once the med's stopped, care is going to focus on preventing fluid loss and infection. Remember that when the skin barrier is damaged, it's going to behave very similarly to burns, which is going to increase the risk for dehydration and infection. So nursing care includes administering IV fluids to prevent dehydration, providing wound care with moist dressings to prevent infection, monitoring for respiratory complications if those mucous membranes are involved, and of course, administering analgesics for pain. So when you hear SJS, just think, stop the drug and treat the skin like a burn. Now let's move from a medication reaction to a viral infection that hides in that nervous system. Next is shingles, also known as herpes zoster, which occurs when the varicella zoster virus, that same virus that causes chickenpox, becomes reactivated later in life. The key clinical clue is a dermatomal rash. That means the rash follows the path of a single nerve appearing in a unilateral linear vesicle, and it'll be on an erythematous or red base. Clients report pain before that rash starts with burning and itching. So your client shows up with a unilateral linear line of vesicles. What will you do? Well, here is your NCLEX emphasis. Shingles is very contagious, and we must initiate contact and airborne precautions until those lesions crust. Treatment will focus on treating pain and protecting that skin. So we administer analgesics like NSAIDs, acetaminophen, or even nerve pain like gabapentin. And antivirals are given like acyclovir to decrease severity and pain. Now, we need to protect the skin barrier to prevent any secondary infections, so we teach clients to keep those lesions clean and dry and avoid scratching. I know it's itchy, but they cannot scratch because that will further damage that skin and increase that infection risk. Clients can also apply calamine lotion to help reduce that itching sensation. Now, when talking about shingles, prevention is key. So remember that it's a reactivation of that chickenpox virus. So how do we prevent that reactivation? Well, we recommend the zoster vaccine for clients that are 50 and over to reduce the risk of shingles recurrence. Now let's move from viral infections to bacterial skin infection. That's cellulitis, an acute bacterial infection of the skin and subcutaneous tissue, most commonly caused by strep or staph, including MRSA. Now our classic symptoms are easy to remember. Think infected skin. So red, hot, swollen, painful skin. Clients can also have fever and chills. Now here's where nursing assessment is important. Cellulitis can spread quickly through the tissue. So as the nurse will assess for the spread by drawing a line around the redness with a marker. This will allow us to monitor if the infection is spreading beyond those borders. Additionally, the nurse should monitor for complications like sepsis. Now we want to treat that infection. So how will we do that? Well, we'll administer antibiotics, either oral or IV, depending on the severity. We also want to perform other interventions to help promote healing and drainage and prevent infection. So this will include elevating the affected limb to reduce swelling, and we'll want to apply warm, moist compresses to improve pain and promote drainage. Time for your first quick check. Pause and answer. What is the priority intervention for SJS? Remember, discontinue that trigger medication. So remember those 3 A's, antibiotics like sulfa drugs, anticonvulsants like lamotrigine, and allopurinol. What isolation precautions should clients with shingles be on, and when can precautions be stopped? For clients with shingles, they need to be on contact and airborne precautions until those lesions crust. How do you monitor for the spread of infection in a client with cellulitis? Remember, we'll mark those borders to monitor the spread. Now that we've talked about infections, let's switch to something nurses help screen for: skin cancer. Skin cancer is a skin malignancy and it's caused by UV exposure. So think sunlight and those tanning beds. There are three main types. We have basal cell carcinoma, which is a pearly lesion with rolled borders, and this is slow growing. Squamous cell carcinoma, which is a red, firm lesion with a crust. But the big one to know, of course, is melanoma, which is that irregular, multicolored, highly metastatic, and the most dangerous. So what if you're assessing your client, they have a mole on their back, and you're wondering if it's cancerous? How will you assess the suspicious lesion? Well, to assess any suspicious lesion, we're going to use the ABCDE rule. A is for asymmetry. So look at the shape of the lesion where a concerning mole is not symmetrical, meaning one half does not match the other half. B is our border irregularity. So examine those edges. Benign moles usually have smooth, well-defined borders, while suspicious lesions often have irregular, jagged, or poorly defined edges. C is for color variation. So assess the color of the lesion. A normal mole is typically one uniform color, while melanoma may show color variation, such as different shades of brown, black, red, white, even blue. And D is for diameter. So check the size. Lesions that are larger than 6 millimeters, which is about the size of a pencil eraser, should be evaluated more closely. And E is evolving. Now, this is something the client's going to have to be watching over time. You have to ask whether that lesion has changed over time. Any mole that grows, changes color or shape should be evaluated by the healthcare provider. So for example, let's say your client's lesion shows a diameter of 8 millimeters and border irregularity. What should the nurse anticipate for diagnosis and treatment? Well, the lesion will be biopsied to confirm skin cancer, and depending on the type and severity, it can be treated with either cryotherapy to freeze the lesions and destroy those abnormal cells, surgical excision such as Mohs surgery where skin's removed in microscopic layers. Of course, there's chemotherapy and radiation, and last are topical treatments like fluorouracil. Now, prevention is obviously key, so what can you teach clients to prevent skin cancer? Well, one of the most important roles that we play as nurses for skin cancer is prevention teaching. So remember that the biggest risk factor for skin malignancy is that UV exposure. So most of our teaching is about protecting that skin. This includes avoiding sun from the hours of 10 a.m. to 2 p.m. and avoiding those tanning beds. Wear protective clothing like long sleeves and hats, and use sunscreen and reapply frequently, like every 2 hours after sweating or swimming. And we want to encourage monthly skin checks to check for those ABCDE findings. Now, our final condition involves the opposite of sun damage. We're talking extreme cold exposure. Frostbite occurs when the skin and underlying tissue freeze after prolonged cold exposure. Because that skin is frozen, it's going to be cold and pale. Clients might feel tingling or numbness because of decreased circulation, and severe frostbite can lead to blisters or blackened necrotic tissue. So you have an older adult client in the ER that was found wandering in shorts and short sleeves in the cold. His skin is cold and pale. We are worried about frostbite. What will you do? Well, the key intervention here is rewarming that tissue safely. So first, remove any clothing or jewelry that could be constricting the extremity, and then we'll start to rewarm the client while assessing for hypothermia, like intense shivering and lethargy. So how will we rewarm? We need to take the frozen area and thaw with a warm water bath. Now, when we're cold, we often rub our arms to warm up, right? But we never want to do that to frostbitten tissue. That skin is so fragile, and this could cause more damage. So for that reason, do not massage or use any dry heat. And for that same reason, we also want to avoid any friction and weight on the affected area. The rubbing of blankets or extra weight on that fragile skin could cause further tissue damage. Now, as you rewarm the client's going to feel pain. So we'll administer analgesics and elevate the extremity after thawing to reduce any edema. And we'll monitor for complications like infection, compartment syndrome, or gangrene. Amputation could become necessary here. All right, time for your last quick check. Pause and answer. What 3 things should be taught to prevent skin cancer? We want clients to limit the UV exposure. So that's that sunlight between the hours of 10 a.m. and 2 p.m. and tanning beds. And they should apply sunscreen and wear protective clothing. How do we assess skin lesions to determine if they are potentially cancerous? Well, they need to use the ABCDE mnemonic. So A for asymmetry, B is border irregularity, C is our color variation, D is a diameter over 6 millimeters, and E is our evolving appearance. How should you rewarm an area affected by frostbite? Should you massage the area? We'll rewarm with a warm water bath to thaw that skin out. And no,